Hi everyone, welcome to ResearchMD.com. Another great presentation today. We're going to teach you everything about Thyroid Storm. That's our whole purpose. We've been doing lots and lots of lectures on endocrinology, right? Our plan is to finish every topic in endocrinology, a very tough subject for a lot of people, and we have covered posterior pituitary hormone, anterior pituitary. Now we have reached thyroid, and we're going to teach you everything about Thyroid Storm, my friends, okay? Again, my name is Pramil. Cheriyath. I'm a practicing physician in the United States, program director, internal medicine residency, transitional residency. I teach medical students on a regular basis, also an associate professor of medicine, two large medical schools. So let's get into our topic right here, Thyroid Storm. First of all, what do you have to look? Look at the definition, right? So let's read the definition. Life-threatening. If you miss this, patient could die. Okay, very dangerous situation. Life-threatening, severe thyrotoxicosis, affecting multi-organ dysfunction, mainly CVS. You got thermoregulatory, GI, hepatic, CNS. Okay, again, the word I want you to remember is life-threatening. If you miss this as a physician, you could get into trouble, okay? And then it's also known as Thyrotoxicosis, the other name if you want to remember. Now, epidemiology, let's look at it. The prevalence, if it is 16% of prevalence if the patient admitted to the hospital with the thyrotoxicosis, okay? And of course, just like everything else, females is higher. If they have Graves' disease, the risk is extremely high. I mean, extremely high. Now, the next thing we have to know, like, what are the precipitating factors we need to know? What is causing this, like, thyroid storm? Let's start with the systemic. If there's an infection, trauma, surgery, okay? Endocrine causes famous is like DKA and hyperosmolar coma, and then drugs or hormone, any kind of withdrawal of antithyroid drugs, iodine administration, amiodarone, pseudoephedrine, and then you got anesthetics, salicylate, aspirin is also very, very important, okay? And the interferon. Now, then look at the cardiovascular. If the patient started having MI, CVA, pulmonary embolism, and all of this could be like precipitated thyroid storm. And then OBG also is important, like labor and delivery can happen, eclampsia, and also radioactive iodine therapy can also. That's one of the other precipitating factors, okay? But the most important thing, my friend, 25% unknown. Nobody knows, okay? So even if you don't find a cause, always think there could be thyroid storm, okay? 25% of the time you will not find a cause. What's the next thing to do? We have to look at the pathophysiology, right? What is the pathophysiology? Hyperthyroid state. So your free 4 T3 and all of this kind of increase. And then you got combination of hyperthyroidism plus precipitating factors. What does it lead to? Increased thyroid hormone and also shift from protein bind to the free form, okay? And then sudden increase of metabolism, okay? And then you can have adrenergic hyperactivity. You can also have thyroid receptor hypersensitivity also, okay? Now, all of this can lead to exaggerated symptoms of hyperthyroidism and organ damage, okay? It's important to know the pathophysiology because that's how we treat this patient, okay? Now, let's look at the symptoms. First of all, let's look at the thermoregulatory system is affected. You can have fever, and then you got CNS, agitation, extreme lethargy, delirium, psychosis, seizure, coma, all of this CNS, very significant. GI, you look at nausea, vomiting, diarrhea, and abdominal pain. Jaundice, my friend, once the patients start developing jaundice, the mortality rate is like extremely high. Just be careful when you talk about jaundice. That's why you put it in the red color right there, okay? Don't forget it. Now, CVS, again, is another important system, can affect tachycardia, pedal edema, pulmonary edema, but always look for atrial fibrillation, okay? Now, how do you diagnose this? The word is clinical diagnosis, but of course you can check the thyroid hormones, no problem. But luckily, what do we have? We have a scoring system can help you make the diagnosis. What is the name of the scoring system? You got Birch and Wojtowski score. Birch and Wojtowski score, you can Google it. I think, some of the calculators, you can find it, you can put it in there, right? So you got like so many parts in there. The first thing that you look at the temperature, okay? So temperature between 99 and 99.9, you give like 5 points. 100 to 100.9, 10 points, 101 to 101.9, 15, 102 to 102.9, 20, and 103 to 103 by 25, and 104, you get 30 points. Remember that. You calculate all of that. Let's come to the CNS. You can put absent, mild agitation, moderate, and severe. If it's like seizure and coma, that's a severe, you give like 30 points. And if it is moderate, like delirium, psychosis, you get like 20 points, okay? So you add all these points together. Look at the CVS, you look at the tachycardia from anywhere 90 to 130. If it is greater than 140, you use 25 points. And then you have CHF, severe pulmonary edema, then you get 15 points. Atrial fibrillation, if it is only, you have to look at is present or absent. If it is present, you get 10 points, okay? So it's important to look at all these things. And GI hepatic, if the moderate nausea, vomiting, and abdominal pain, you give 10 points. And then severe jaundice, we talked about, is a bad sign, you get 20 points for that. And then precipitating event, if you can find it, 0. I mean, if it's absent, 0. If it is present, you get 10 points. But remember, 25% of the people you don't get. That's why you got low points. Okay, 25% of the person does not find a precipitating cause. Now we calculate all the score. What would you do? If it is come back, I mean, all of this, you calculate and you get a cumulative score. If it is greater than 45, you said, your job is done, you got your diagnosis. 25 to 44, you said, hey, there's something coming, impending, okay? Just be careful. Thyroid storm is knocking on the door, my friend. And less than 25 is very unlikely, okay? Now, so we found out the diagnosis. What's the next thing that you have to do? We have to ready to get treated, otherwise the patient is going to die, right? So what are the treatment? First, main thing, supportive care, IV fluids, make sure airway and everything is okay. The next thing is adrenergic hyperactivity, right? You have to inhibit that. What's the drug you give? Beta blocker. Everybody knows that. Okay, and then inhibition of new thyroid hormone synthesis. So you can give the the usual methimazole or PT. You could use it. The next step is inhibition of thyroid hormone release. For that, you have to give iodine. You can give like potassium iodide or sodium iodide. You can use. And then you can also use lithium, and you can also L-carnitine could be used it also. Okay, but the things to remember, you cannot, I mean, before you give iodine, do stepwise. Like, I mean, you cannot, before you give iodine, 1 hour before, you should have given the methimazole or PTU. Thionamide should be given. Remember, very, very important point, okay? And then, if you cannot find, if there is some kind of reaction or cannot use contraindicated iodine, you can use potassium perchlorate. And if the patient has amiodarone-induced thyrotoxicosis, use potassium, potassium perchlorate also. Very, very important, okay? So stepwise, now next one, prevent the peripheral conversion. Everybody know we give steroids, right? But we need to know what is the reason we're giving steroid. That's because you're trying to prevent the peripheral conversion right here. And then number 6, prevention of thyroid hormone absorption. You can use cholestyramine, and then treat the precipitating factors. We talked about 25% you may not find it, but if you find it, you treat it. And the last one is everything settled down. You have to go for the definite therapy. What is that? Radioactive iodine or surgery, definite curative, right? Okay, now I'm just going to stand back, look at our board, look at the main things like one more time and see what's going on. Everybody know the diagnosis, life-threatening. Remember, if you miss it, patient is going to die, right? You got the severe thyrotoxicosis, affecting multi-organ dysfunction. Remember, more common in female, and if they have underlying Graves' disease, that also can be affected, okay? Very high risk, and you got large number of these precipitating factors. The word to remember, 25% of the person, 25% of the time you may not find it, okay? And then you come up here, this pathophysiology, you got 2 combinations working together, deadly combination, hyperthyroid state plus precipitating factors. Increased thyroid hormone, shift from protein bound to free form, sudden increase in the metabolism, adrenergic hyperactivity. There's a thyroid receptor hypersensitivity also. So all this hormone is going to go crazy on every part of the system. Remember, thyroid hormone acts on every system in the body, right? And then we got this nice diagram. We know the CNS symptoms, agitation can even lead up to seizure and coma. CVS, think about atrial fibrillation. And GI hepatic, you should know jaundice, very bad sign, okay? Now, once we do that, how do you diagnose it? It's a clinical diagnosis, but the word to remember, Birch and Wojtowski score is going to help you out to make the diagnosis. You have all this scoring system you can use based on the temperature, CNS, CVS symptoms. You add it up, my friends, cumulative score greater than 45, highly suggestive. That means your diagnosis is there. You made the diagnosis, then you can start treating. 25 to 44, knocking on the door. Impending is the word, and less than 25, forget it. It's not thyroid. It's not thyroid storm. Okay, now we have to treat it. Everybody know the steps we have to give. We have given 8 steps. Okay, don't forget the 8 steps. First one is the supportive care. Number 2, you look at this adrenergic hyperactivity. You gave beta blocker. Number 3, you have an inhibition on new thyroid hormone. You gave antithyroid drug. Methimazole I would use. PTE is second choice. And then you have inhibition of thyroid hormone release. You give iodine, but make sure before you give iodine, you have to give methimazole 1 hour before. In amiodarone-induced thyrotoxicosis, don't use iodine, use potassium perchlorate, okay? Number 5, prevent peripheral conversion. Everybody know we give steroids in this. We need to know what's the reason. We're trying to stop the peripheral conversion, and then prevention of thyroid hormone absorption, cholestyramine, and treat the precipitating cause. And the final, once everything's settled down, we have to go to the definitive therapy about, to treat this, which is radioactive iodine therapy or surgery. Thank you so much for watching. We'll be back with another presentation soon. Please subscribe to our channel. So we still have a lot of presentation to do in endocrinology, my friend. God bless, study hard.